Hey everybody, this is Greg with Medical Muscle. This video is part of a series where I'm going to be discussing the core rotations during third year in medical school. And I'm going to start it off with internal medicine, which is very important. Internal medicine basically is the biggest chunk of step 2. Okay, so most of the questions have to do with medicine. And depending on how you do on the shelf exam for internal medicine, we'll sort of give you an idea of how you're going to do on step 2, okay? Because up to 60% of the content can be internal medicine. So let's get started. It's a 12-week rotation, and at the end you have a shelf exam that you're studying for the whole time. Halfway through the rotation, our school required us to do a practice mock exam just to get an idea of how we're going to do. That might change depending on what school you're in, but that's what we had to do. So let me break down what the 12 weeks looked like. So for me, the first 4 weeks were outpatient. I did outpatient in a bunch of different specialties: rheumatology, geriatrics, cardiology, which was great because the hours were pretty easy. It was a 9 to 3 usually, or 9 to 2. Very easy day. The only downside was there was a lot of driving between each facility because these are all outpatient clinics, and some of them were a few hours away, and I would have to somehow make it back to the main hospital for didactics. So that was the only downside, but I felt like I learned a ton during outpatient. So cardiology, obviously you're going to read EKG strips. You're going to have to know what medications are appropriate for, like AFib, that's super common. Congestive heart failure, all that stuff. It was very interesting, and I felt like the cardiologist was a lot of fun. He made it a good learning environment, the outpatient guy. And then inpatient cardiology was a different doctor. He was, really good. He would quiz me and see if I knew what the best plan was, what was going on, what was the best plan, and what was the best dosage per medication. And I felt like I learned a lot, and it's important because cardiology is a big part of step 2 and your shelf exam. So you need to know cardiology. You need to know how to read EKGs. You need to know medications for the heart. Very important. Rheumatology was very interesting. I felt like I learned quite a bit. I actually got some questions right because of that rotation. It's a popular topic on your shelf exam. Lupus, that's one that's super high yield. You're going to see lupus for sure. Okay. I did outpatient geriatrics. That was a lot of like medication management, seeing how, their IADLs, like how are they living independently? Can they live independently? What can they do? Assessing that kind of stuff. I wrote notes for them. All in all, it was just a pretty easy rotation, that part. Did a few days of inpatient hospitalist work. We would go and talk with patients in the ED, see what was going on, things like that. I thought it was really interesting. Actually, during that rotation, just a little side note, I heard a murmur that wasn't documented. I was like, wait a second, this is really interesting. And then sure enough, someone came in and like, yeah, that's aortic stenosis. So really fun. Okay, so the next 4 weeks was probably the most challenging part of the rotation in internal medicine, and the most challenging part of the any rotation that I'd done, period. Harder than surgery, harder than anything else was the ICU. The CCU. We did the cardiology critical care unit. It was so tough. You basically had to know, you had to incorporate every piece of medicine into that rotation. I mean, it just required you to be on your toes at all moments, and you had to assess every single system. So when you're assessing the patient, and you're presenting the patient to the attending, you're going through every single system: endocrine, GI, respiratory, urinary, every single one, neuro. You have to do a physical to assess those things. You have to make sure that you're covering all your bases, because sometimes these patients in the ICU or the CCU are have multiple things going on, and sometimes we really don't know what the main cause of, their failure is. Sometimes it was interesting and ended up being like an autoimmune thing. Okay, so you have to go through every single system to find that. I felt like the doctors were the most intelligent, the attendings were the most intelligent, and they were very, I don't want to say hard. They pushed the students to be their very best and to think outside the box. And they were the hardest graders. They were tough because you really needed to know everything. I know I was never pushed that hard on any other part of my rotation in internal medicine. I had to write notes, had to manage at least 3 patients, present them every single day. You get there early, you get there at 7 o'clock, and rounds were just grueling. We're going through every single detail on the patient. It could be, up to 15 minutes, 20 minutes on just one patient discussing what the plan is. Okay. So I felt like it was very helpful for the shelf exam. Extremely helpful because there's so many medications that you have to think about, so many different conditions. There's some cool procedures that you could actually do. So that made it interesting. Yeah, I thought it was hard, but I thought it was really interesting. And I would tend to, just for like, what's the normal day? I'd get there a little before 7, and I would go and just chart check, see how they did overnight, see if any updates from the overnight team, and then go do the physical on the patient. If they were off the ventilator and can actually talk, then I would talk with them and see how any updates. But most of the time they're sedated and they're on a ventilator, or they're not sedated and they're on a ventilator and they just can't speak. So you have to kind of figure what is the best way to get information from them. The physical is very important, doing a physical, so you must bring your stethoscope. A lot of COVID, a lot of cancer, a lot of heart failure, a lot of drug overdoses. And I'm going to be honest, that was where I saw the most patients pass away. So emotionally, it can be very tough. These patients are critically ill, okay? And they're sometimes being held on just by a thread. So very, very, very tough rotation. And usually we'd get out by 3 or 4 o'clock, so 7 to 4. Okay, so not crazy hard. Okay, so the next 2 weeks that I had were geriatrics. Geriatrics, I had a blast. It was awesome, inpatient geriatrics. The team was good. I love geriatrics because it's a mix of a lot of different specialties. So you have, obviously, medicine, because you have to assess, their drugs and things like that. But you have some neurology, and you also have psychiatry mixed all into one field. Really cool specialty. So yeah, you have to do a lot of MOCAs, a lot of mini mental assessments, a lot of them. Some get up and go type things like do a timer, a lot of assessments. You're trying to see how quickly can they get up out of a chair, what's their mental status, things like that. And you're doing a lot of them by yourself. I got really good at going through from memory and asking these questions. The patients were really, I thought for the most part, they're really nice, really cool people. Just a lot of them had, dementia or, a lot of issues. Usually falls are what put them in, but then you could see probably what their next big challenge would be living on their own because there was some neurocognitive decline. So you have to kind of make all these assessments, and when you're making the plan for that, you have to say, okay, should this person go home? Where should they go? What do we do with this person? Okay, is it safe? Are they safe? A lot of calling the families, seeing what their point of view is, if they can give any other information. So that's inpatient geriatrics. The hours, I could say, were amazing, right? We only had to be there from 9 a.m. to, we'd go 9 a.m. We would go just make a general discussion of who's going to take who. We would chart check, go see the patient, usually on our own, and then come back and present that to the attending. And that would be like at maybe 11. and then we'd go for lunch, and then if there was anything we had to do after lunch, usually like go check up on the patient one more time, but we were usually out by 1 or 2. It was really cool. So 9 to 2, pretty easy for 2 weeks. Learned a lot then too, learned a lot. Okay, and the last 2 weeks that I had was also fairly challenging. I could say it was one step under the ICU. It was just inpatient, working with the hospitalists. So we would get there at 7 a.m. and we would have patients that we'd have to go see, usually either ones that we had seen earlier that week, and then we would take on a new patient. As the weeks progressed, we would take more and more patients on. And this is all kinds of inpatient stuff all over the hospital. And same thing, we would get an idea of who we were gonna go see. We would go see them, go talk with them, do any kind of follow-up, and then we would sit down and discuss with the attending, present the patient, any updates, things like that. Similar to ICU, where you're going through a lot of the systems, but not as in-depth, and trying to make a plan. The attendings in that part of the rotation were very heavy on, can you make a plan? And that's what we were graded on, okay? So it was also intense. Grading was tough during that period. I enjoyed it quite a bit. I thought it was very interesting. Usually we would have that heavy duty talk, then we'd come back after lunch, any other updates. And usually we were out by 3, or usually about 4 o'clock. So 7 to 4, that was pretty normal. Maybe even a little later, 7 to 5, depending. And that was the inpatient stuff. All right, guys. And the shelf was tough. I think, and I'm gonna be honest, I think SGU prepared me well. I think it prepared most students well for that shelf. I think most of SGU's topics from term 1 all the way through term 5 really focuses on internal medicine stuff. So that actually, that the content in that wasn't that hard, because I feel like we had skimmed a lot of it. The questions are tough, okay? But at least I had a good base going into the exam, okay, and going into that rotation. And a lot of what I saw during the rotation came up in questions. That's the beauty of actually participating as a clinical student. I mean, you're gonna see this stuff, and once you see it in real life, you don't forget it, okay? All right, guys, so that is the internal medicine exam. Please like and subscribe if you can. And, I'm gonna give you more updates on more electives. All right, guys, talk to you later.